Okay, welcome everyone and good evening. My name is Angie DePoy and I'm the Education and Research Liaison for the Fenway Foundation for Frisian Horses. For those of you who might be unfamiliar with the Fenway Foundation, we are a nonprofit 501c3 that's based just outside Appleton, Wisconsin in the USA. The Fenway Foundation is dedicated to preserving and enhancing the longevity and health of Frisian horses through three primary areas: rescue, research, and education. And while we're waiting on some more folks to log on, I just want to go over some quick administrative items. So everybody will be in listen only mode for the webinar. We will stop periodically throughout the presentations to allow for questions. So as you're listening and you might think of a question, you can go ahead and type it immediately into that little Q&A button down at the bottom of your screen, bottom of your toolbar. Just use that to type your question in there. So tonight we're really excited to have you here for this educational webinar on EPM presented by Dr. Sarah Colmer. Dr. Colmer is a fellow in large animal neurology at the University of Pennsylvania School of Veterinary Medicine's New Bolton Center. She completed a residency in large animal internal medicine at New Bolton Center in 2022, and rotating internships at New Bolton Center, as well as the Mid-Atlantic Equine Medical Center in New Jersey. Her research interests are in neurological conditions in the horse, particularly degenerative diseases, as well as endocrinology. So I'd like to now turn the presentation over to Dr. Colmer. Welcome, Dr. Colmer. We are so glad that you are here with us this evening.
Thank you so much for having me, and thank you everybody out there for listening. I hope that this is a subject that holds your interest. I know that it's a pretty popular topic, and hopefully by the end of this, you will have a little bit more of an understanding about it, and I can answer any questions that pop up along the way. So without further ado, we are going to be talking about possums quite a bit, specifically their relationship to EPM. And so the title of this presentation is The Possum in the Room. And we'll talk a little bit more about why that's going to be important in a second. But just to briefly introduce myself, so the bottom left here is a picture of me and my two fur children. I live in Pennsylvania now, but I'm from the Jersey Shore originally, never strayed too far away. But this picture in the center here is New Bolton Center, where I work now. I went to school at the University of Pennsylvania, did an internship there, a residency in internal medicine, and am now doing my fellowship in neurology under Dr. Amy Johnson, who perhaps some of you might recognize the name from either working with her or reading some of her many publications, but she's sort of a powerhouse in the field of neurology, and it has been wonderful to absorb some of her knowledge and experience. And working at New Bolton Center, we have the privilege of working with so many horses, both performance horses like the ones you see up in the top right picture, but also a lot of backyard horses as well, which are at least as important. And so with all of these different horses we get to see, including some Friesians as well, we get the opportunity to deal with and diagnose and hopefully treat a lot of neurologic disease, which is what interests us the most. And so in the bottom right picture here is an image of us doing a spinal tap in a horse that had some really, really severe effects from EPM and actually made a really great recovery. So that was kind of a nice success story. And that's how we like them all to go, but they don't all go that way. And so starting at the beginning, I'm going to sort of go through what EPM is and how it happens, and eventually show you some videos of some horses that demonstrate the things we see with EPM. And then we'll get into some details about prevention. And finally, we'll talk about some of the updates in EPM research that have been happening over the last couple years. So starting small, what is a protozoan? Because the name EPM is Equine Protozoal Myeloencephalitis. And so the protozoan part refers to the parasite. And this is a parasite that belongs to a family called Coccidia. And they are these round little parasites, and they're single-celled organisms. And it's amazing when you think about what one single cell can do to just these gargantuan horses, right? It's just a fascinating thing that they're able to exert exert the effects that they're able to do. And there are many, many species of coccidia, but the two that we deal with when we're talking about EPM, at least up until this point, although research is investigating for potential other organisms, but at this point, it seems like Sarcocystis neurona is the big hitter, especially on the East Coast, but honestly, in general, throughout the country. And then less commonly, we will also sometimes see Neospora husi or husi also play a role in clinical disease in the horse. So those are the two big hitters. And they're primarily in the Western Hemisphere, so just North and South America. And the reason why I even bring that up is because our friends across the pond in Europe really don't see much EPM at all. So they're kind of lucky, although they have a couple other odds and ends that we don't deal with here in North America. But if you've recently imported a horse, just a couple weeks ago, it does make something like EPM a lot less likely if you're seeing neurologic signs. So that's something that we, ask when we're taking a history on a horse that we're looking at for neurologic disease is if they were imported, was it recent? And that might have implications on sort of how we rank our options for different diseases that might be causing the signs we see. So EPM, just to go a little bit into its life cycle, because I do think it's fascinating and relevant, has a 2-host life cycle. And we use the term definitive host, which is the name of the species that sheds the parasite and kind of releases it into the environment. And in this case, the definitive host is the possum. And so that's the one that gets the bad rap with this disease because it's the one that spreads it all over sources of water or grassy fields where your horses live. And so the possum is sort of the scapegoat in this scenario. But there are a lot of intermediate hosts as well. So these guys over here, depending on where you are in the US, that might involve the armadillo, certainly the raccoon and the skunk. So basically this parasite at some point in its life cycle has to go through this phase where it's housed in one of these animals listed here. And then eventually the possum consumes some aspect of the muscle, etc., that's infected with the organism at this stage in the intermediate host. It finishes development and gets shed by the possum. Lastly is our dead end host. And this is actually really important because when we think about EPM, it's a disease that is not one that we consider is spreadable from one horse to another. Unlike other diseases that are really important in terms of biosecurity, like herpes virus, for example, which can be spread by respiratory droplets from horse to horse and causes huge biosecurity concerns that can shut down entire horse shows, barns, or even hospitals, as has happened. The dead end host of the horse means that when the parasite causes disease in the horse, and this is rare that it does, but when it does, that horse is not going to go on to shed it in the paddock and give it to other horses, right? So 2 points on this, and then we'll move on. One is that the way that the parasite causes problems in the horse is that once the horse consumes it, it might take hold within the horse and eventually travel to the central nervous system where it causes disease. This is actually relatively rare. So a lot of horses, especially in my tri-state area, have been exposed to the parasite and they've made antibodies or titers against the parasite in their blood, but that doesn't mean that they actually have disease in their central nervous system. And so we'll talk about that a little bit more later, but I think it's important to kind of bring that up.
I do have one. Oh,
yes.
Sorry. Were you finished on this?
Oh, no, we can address a question.
Okay, I have one quick question from Janine, and she wants to know, can rats or mice cause EPM as well? Like, are they involved in any way, shape, or form? We see them a lot in barns sometimes. Are they a factor in this at all?
That's a really good question. In terms of the definitive host, the possum is the only definitive host that we're aware of for Sarcocystis neurona. But I'm glad that this question was brought up because it reminds me to remark that we don't know a lot about the life cycle in Neospora, which is the other coccidial organism that causes EPM. So it's unknown what aspects of that life cycle involve different species. So it's possible. It's not a standard definitive or intermediate host for EPM, but it's possible. So usually mice and rats are not as implicated in this disease process, as far as we know. Any other questions up to this point?
That's the only one right now.
That's a good one. The last point I'll make about the dead end host comment is that even though the horse doesn't spread the disease to other horses, we might know of some farms, like we actually have a farm near New Bolton Center where there seems to be almost like an endemic, I'll say, in that there are multiple cases, it seems like per year, of true EPM on this farm. And so some farms, maybe by way of their environment and having a big possum population or what have you, they may see more cases than other areas. Like it seems like lightning seems to strike the same place twice on those farms. And again, we don't think it's spreading from horse to horse, but it seems like some environments, for whatever reason, might make this more of an endemic situation where there are more common cases on one farm. So we'll talk a bit later about ways that we can try to do our best to prevent EPM and how we address that. So who gets EPM? That's a really good question to ask, because it seems like so many horses see this pathogen and consume this pathogen, and only some horses get the actual disease, right? So who gets it? Literature is pretty limited. We do need to churn out some, I think, updated retrospectives, meaning looking through our hospital records, both within the university and other hospitals and private practices and things, and try to get a better sense of this. But in the literature, what is known, or what was known a few years ago, is that it seemed like a good number of cases happened in younger horses, so those under the age of 4, and then also another subset of horses that seemed over the age of 8. And it certainly doesn't discriminate between breeds. We've diagnosed it in all sorts of breeds, oftentimes thoroughbreds and standardbreds and warm bloods, which just make up most of our case population. But we'll see it in anything Tennessee Walkers, of course, Friesians as well. And there doesn't seem to be a sex bias. So in terms of like mare, stallion, gelding, it doesn't seem like one is more likely to get the disease than the other. And then again, I mentioned that it's typically sporadic, meaning that it's usually one horse on a farm at a time, but there's always that potential for endemic cases. And possums and wooded areas seem to be factors that increase risk of developing EPM. So how do we diagnose EPM? There are 3 big things that we take into account. So before we even think about testing a horse for EPM, it's important that we're actually looking at a horse that has neurologic disease. And the way that we figure that out is by doing a neurologic exam. And I'll talk about the different parts of that and what it looks like if you're not familiar with it. The second thing is that we need to also rule out other diseases that might look like EPM, because EPM has actually been called the great imitator. It can look like so many things, and I'll show you a couple examples of those, but it can look like weird lamenesses, it can look like head trauma, it can look like wobblers, it can look like EDM, our neurodegenerative diseases. So it's important that we make sure there are no other causes of the clinical signs. And then lastly, we want to find proof that it's happening in the horse. So we want to find proof of exposure and ideally proof of active infection. And I will explain what that means in just a couple slides. But first, we're going to talk about what it looks like clinically and what we see in the hospital that makes us suspicious of EPM, and things that you can look for at home. In school, we always learned this as the 3 A's. It's sort of the easy way to remember the classic signs of EPM. The first one is atrophy, and usually that refers to muscle atrophy or muscle wasting. Usually the muscles that we're talking about are the top line, or the epaxial muscles, sort of along the top of the back. And then the other area where we'll often see atrophy is across the gluteals, so across the rump of the horse. I'll show you some pictures. The second A of the 3 A's is asymmetry, meaning that there is a difference one side to the other in the clinical signs. This could be asymmetry in the muscle atrophy, or it could be asymmetry in different cranial nerve problems, which we'll talk about, or asymmetry in the ataxia, meaning that maybe the horse is really incoordinated on the right side or the left side. The reason that asymmetry makes us think of EPM more often is because other diseases like neurodegenerative disease, or EDM, is usually symmetric. So the sides are usually affected in the same way. So if we see asymmetry, that increases our suspicion that EPM is something we're dealing with. And then the last A is ataxia. Ataxia is a fancy word for a loss of coordination. And I'll show you quite a few videos in a couple slides that illustrate ataxia, I think, pretty well. So this image on the right side here is a really beautiful illustration of asymmetric gluteal atrophy. So see on this horse on the right side, he has a nice round rump on the right, and then he has this very concave sort of silhouette on the left side. And the best way to look at the gluteal musculature is by standing right behind your horse and having him stand really square, and then comparing one side to the other. The horse on the left, it's kind of hard to appreciate, I think, in this picture, but I should have a better one coming up in a few slides, has a little bit of atrophy across his apaxial musculature as well. So those are the two areas where we really try to see atrophy. And then lastly, the gluteals on this horse, I think you can probably appreciate that instead of having a nice round silhouette to the rump here, it's sort of flat and has some harsh angles to it. And that's also suggestive of some atrophy across the gluteal musculature. So when we move, do we have a question?
Yeah, I have a couple here.
Sure.
Is there any data on which side of the horse might be affected more often than not, or it's pretty equal?
No, it seems really random, honestly. I've never read any pieces of literature that tell you right versus left, which doesn't surprise me because it seems like the clinical signs, the reason that they happen is it just depends on where the parasite has migrated within the central nervous system. And so I don't think the parasite is particularly smart or has like preferences for one side versus the other. It's just quite random. So unlike some disease processes, like some wobblers that have symmetric ataxia, or some horses with neurodegeneration, which we know happens on equal sides of the spinal cord and brain and thus causes equal signs, the asymmetry is because it's just wherever that parasite migrated. So there's no real side predilection as far as we know.
And does that ring true the same for the symptoms they would display depending on where it goes
Correct.
at? Okay.
Yep. So the
that's why the
symptoms,
symptoms vary so much from horse to horse.
yeah, that's such a good point. The symptoms are essentially a direct result of where the parasite has migrated. And in some horses, it can be symmetric. It just kind of depends on the distribution. It's really hard for us to know exactly which part of the central nervous system is being affected until we find the evidence at postmortem, but we can use the clinical signs to help us figure it out. So there are certain parts of the brain and certain parts of the spinal cord, which I could talk about for days, that have very specific clinical signs. And we call that process neurolocalization, where we look at the horse, and I'll show you an example of like horses with different cranial nerve issues, meaning problems in their face reflexes and responses. And so like if a horse is, you know, blind in this eye and circling in this direction, there's a problem on this part of the forebrain, versus if a horse has a head tilt this way, it's going to be on this side of the midbrain. So like there are different things that we can look at, like clues almost, that tell us where the problem is likely occurring, but that's why it happens.
Okay, and the last question I have for now is, does stress or some kind of poor immune system indicate that a horse, you know, would get it more often than a completely healthy horse? Or an
That's a
unstressed
great question. Yeah. So that, I think I bring that up in like towards the end of the presentation, but it's a great point. So we don't know why some horses seem to get EPM and others don't, even if they have like identical management situations. Maybe it's bad luck. Maybe this one just consumed more possum poop than the next. But it does seem like events, like stressful events like long trailer rides or horse showing, really intense competition like race horses, those horses do seem to have an increased propensity for developing EPM, and it is suspected that there could be some role for the immune system and immune compromisation in the development of the disease. So it is one of the prevention strategies, essentially, is to keep your horse as healthy as you can, which is easier said than done, but it just kind of stresses the importance of a healthy and robust immune system. And to that point, when we're dealing with acute or like immediate new EPM infection, we try to stay away from steroids if we can, because steroids are used to decrease inflammation, which is awesome, but they can also quiet the immune system and keep it from working at its best. So sometimes we will hold off on using steroids in the beginning because we want the immune system to work as well as it can. There are other times where we need that anti-inflammation regardless, so we'll use steroids anyway. So don't be, dissuaded if your vet recommends steroids. But I bring that up only because the immune system is thought to play a role in preventing and potentially helping treat the disease. But it's hard for us to know exactly which horses are going to get it and which diseases or immune compromise lend themselves to EPM most commonly. So our neurologic evaluation, my favorite thing, do it multiple times a day. It honestly never gets old to me, but it probably gets old to some of my students. But nevertheless, the neurologic evaluation is really important. And we have sort of three main parts of it. The first one is when we look at these horses, we assess their mentation, which is a fancy word for sort of how bright, alert, and responsive they are. And so horses can be bright and alert, or they might be dull and minimally responsive, or somewhere in between. If their demeanor is inappropriate, usually that tells us there's a problem in the brain. So that is sort of a clue for that neurolocalization. The second part of the exam is cranial nerves. So we look at things like facial symmetry, which when it's abnormal, they might have like an ear droop, an eyelid droop, a muzzle deviation. We look at facial sensation. So you'll see us poke the horse all the way from the ear down to the nose. And then on the other side, we'll look for vision loss. We'll pull their tongue out of their mouth and look at their tongue tone and how well they retract it back in. And we'll look at swallowing as well, among other things. And all of these can be affected by EPM. When they are affected, this also tells us that the problem is likely in the brain. So problems in the brain will give you all of those things that I just described. And then the last part that we'll do for our exam is the gait evaluation. So this is where we have the horse walk in tight circles, go up and down hills. We'll do a tail pull to look for weakness. We'll have them walk up and down a curb sometimes, all those little things. And we're looking for mistakes in foot placement. And when we see those issues, that suggests more of a spinal cord problem. And EPM can affect the central nervous system anywhere from the brain all the way down the spinal cord, and then even some of the nerves coming off the spinal cord. So some horses will have effects of EPM that are like really local to one leg, and you'll see all this muscle atrophy of one leg even. So the tagline for EPM, if it was like a Barbie doll that had like a phrase, would just be that it does anything it wants. EPM does whatever it wants. And that's like an adage that we say in school. It's an adage that we use all the time. It can look like so many different things. So what do we look for in the gait evaluation? So many things. We look for toe scuffing. So when they drag their toes across the ground, do they have sort of like a slapping gait, which I'll show you some examples of? Do they trip and fall? That's a pretty obvious sign that there's something wrong. Are they hypermetric, which is a fancy word for floating? We sort of joke a little bit in equine neurology that the difference between a fancy horse and a neurologic horse is a very slim margin. So some fancy horses might actually be a little bit on the neurologic spectrum, but that is a subject for a different day. Some other things that we look for that are not as obvious, I think, are not squaring up. So it sounds silly, and some horses are just a little bit more lackadaisical than others. So if you go out to the barn after this discussion and watch the way your horse is standing, don't get super alarmed if he's not square. But one of the things that we notice in our evaluations is when we're turning them in tight circles or doing serpentines and then we halt them, some horses will just leave their legs in different zip codes and not correct them. And when we notice this repeatedly and very, like if it's very obvious, it does kind of send up a little bit of a red flag that perhaps the horse's awareness of his limbs in space is affected. And that's essentially what happens with spinal cord disease, is that where this little parasite is migrating, or if there's spinal cord compression in a wobbler or degeneration in an EDM horse, the way that it exerts its effects is that the signals from the brain all the way to the legs and back again get interrupted. And so usually the horse loses his ability to know where his legs are in space. And we call that proprioceptive deficits and ataxia. Horses will also exhibit weakness with spinal cord issues as well. So we'll look for weakness by doing a tail pull and things like that. And then lastly, when we circle these guys, which I'm about to show you some videos, you'll look for horses that pivot in their limbs instead of crossing over. So horses normally cross over their limbs, their front limbs and their hind limbs as they're circling. But some horses with deficits will just kind of pivot across a point. So I'll show you what that looks like. Before we get to the videos, we usually use a grading system when we are talking about how severe the signs are. So this is called the Modified Mayhew Ataxia Scale. So Dr. Mayhew was sort of a godfather of equine neurology, and he created this scale from 0 to 5, where 0 is perfectly normal and 5 are horses that can't even stand up, which is what recumbency is. Most of the horses that I see day to day that are not necessarily EPM horses are between a 1 and a 2.5, but some horses with EPM can be all the way to a grade 5. So we can see the gamut with EPM. They can be mild, they can be moderate, and they can be severe. So the video I'm about to show you is a really interesting case. It's a relatively young thoroughbred from quite a few years ago at New Bolton Center who ended up coming in with EPM, and you can see the beginning of his visit, and then he progresses to become quite worse in his signs. And then at the end of the video is happy because he got a lot better and ended up going home. So without further ado, I'll start this video and kind of narrate it for you. So they're doing a cranial nerve evaluation here. They're looking for facial sensation. He seems to have it. So they're checking both sides, looking for any issues. And then here they notice that when they pull his tongue out, he kind of just leaves it out. He doesn't pull it back in his mouth. It seems like he kind of struggles to pull it in. And watch how much he struggles to get hay here. He knows where the hay is, but he just can't organize his efforts to get it. So he's struggling to eat. And as you watch him walk, he's not too bad here, honestly, but compare this to what you're going to see in a few seconds. This is how he presented, but now he gets a bit slow in his limb placement. See how he kind of hesitates there? And as he comes around this turn, he's just taking very careful steps, very long steps too. And his tongue tone's worse. Now it just hangs out. He's really struggling. And at one point, he had to be on complete intravenous nutrition. Here he is wearing a helmet and being really dull and was falling into the wall. So see how unsteady he is on his feet, the poor guy. He's on intravenous support. But after, I believe, 2 or 3 weeks of treatment, he actually ended up improving dramatically and ended up going home, which was a really nice end to the story. It looks like maybe we have a question.
Yeah, so Kate asks, how do we separate some injuries from neurological deficits? For example, she has a mare that has locking stifles, which sometimes show up mildly, like the symptoms that you just described earlier, like not wanting to cross her legs, etc., without fully locking. So how do we tell the difference? Do we need a vet? Is there something we can do at home?
That is such a good question. And I'll try to make this answer as brief as I can. So we deal with this all the time in the hospital. We have horses that come in for lameness evaluations that end up on the neurology service. And we have horses that come into the neurology service that end up with our lameness service, or a combination. I mean, oftentimes, and we're so lucky to work at a hospital, right? Because we just can sort of combine forces, and general practitioners or your regular veterinarians are just doing all of it. They're amazing. And so the best way that we try to decipher lameness versus neuro, or at least try to figure out what the most prominent contributor to the gait deficits is in a couple ways. So one, neurologic deficits are most easily seen at a walk. And so the exams I'm going to show you in the next couple of videos, and even this video, are all being evaluated at a walk. And horses with neurologic issues, they seem to compensate better at faster speed. So there are things called central pattern generators in the spinal cord that kind of take over. And so it can be a lot harder to see neurologic deficits at faster gaits. So the walk is the best way for us to look for neuro disease. However, lameness is best evaluated at a trot. And so that's one of the ways that we kind of look for where the deficits become evident. The other big way that we try to decipher lameness versus neuro is that usually lameness issues and musculoskeletal issues are consistently abnormal. And what I mean by that is that if you trotted the mare off in a straight line, she's consistently taking lame steps. Neurologic horses are abnormal, but they're usually unpredictably so. So as the neurologic horse is walking away from you, he might take a big step here, a big step here. You never quite know where he's going to end up. And the deficits are not always the same, because the nature of them is usually that there is inappropriate communication between the brain and the legs, versus a lameness where it's a consistent pain in a lot of cases. So those are two big ways that we try to separate lameness versus neuro, but sometimes they are really difficult to decipher. So for us, as part of our neuro evaluation, one of the first things we do is trot the horse off and then like send them away from us and bring them back towards us. And if we see a significant lameness, we usually try to address that first, because that can really impact their foot placement at a walk. So we don't want to condemn a horse to neurologic disease if he has a significant lameness. So usually we'll send them off to our sports med department for them to block the horse, image the horse, diagnose whatever's happening musculoskeletally. And then if the horse is still exhibiting neurologic concerns, we'll address them at that point. So basically having your veterinarian out, if you've already diagnosed locking stifles, that's probably what you're dealing with. But if you have any questions or you think things are getting worse, it's probably worth, having an exam done just to feel as good as you can about it. But it can be so hard, and horses can have more than one problem.
That's definitely true. Christy asks, how long are they normally infected or exposed before they show signs and symptoms of EPM?
We don't know. It's so hard. So at the end, I talk about limitations in research, and one of them was that we were talking about this a little bit before the rest of you guys got on the call, but EPM is really hard to create like in a laboratory setting. So for example, if we wanted to test like treatments and learn about how long it takes for the disease to take hold, if you inoculate horses, like feed them possum poop, we can't do it, because some horses will get EPM from exposure to a couple parasites, and some need a ton of exposure to parasites. And there's no understanding about how many parasites it takes to cause the disease, how long it takes them to get to the CNS, why this horse gets it, why this horse doesn't. And so we don't know. It seems like once horses show signs of EPM, if that's what they're actually dealing with, they tend to worsen pretty quickly over a couple of weeks. So usually if a horse has like a pretty rapid developing course, like, and is in a really downward spiral, that increases our suspicion of EPM versus something like maybe wobblers, which in a lot of cases is a bit more insidious, not always. And then the other thing you have to think about is other diseases can also have rapid progressions, things like rabies even. And so the importance of doing a neurologic evaluation with your vet, having them try to neurolocalize the horse, and giving your vet a really good history and sort of thinking about when you saw the signs start can be really helpful. But in short, we don't know how long it takes once a horse becomes inoculated to when he might show symptoms. We just have no idea.
And last question is from Kate, and she's asked, do you find dullness to be a clinical sign of EPM? Is that one of the symptoms that's on your list that you would look for, or that an owner should be, watching out for?
Great question. So going back to the slide where I talked about sort of like the three parts of the neuro exam, that first part is called mentation, where I talked a little bit about how that's how bright or dull they are. So short answer is yes, dullness can be a sign of EPM, but it also can be a sign of other neurologic diseases. We see it in our neurodegenerative horses a good bit too. So it doesn't pigeonhole them into EPM, but it absolutely is something we can see, because EPM can do whatever it wants.
Okay, that was the last question for now.
All right, perfect. This is a horse at a nearby farm, a thoroughbred racehorse. That is just another example of, oh, hold on. Let me see if we can get that to play. Another example of EPM. He has some atrophy, which hopefully you can kind of see. This video is quick, but there's some concavity here across his gluteals. And as you watch him walk, see how he kind of just tracks in two different lanes, essentially, like his hind limbs are sort of on their own. And you just get this sense that he's not quite sure where his limbs are. He also is dragging his feet and is just kind of slow to maneuver and really hard to keep in a straight line. And see him pivot here. he's a beautiful example of horse not crossing over in his hind limbs. He's just pivoting around a fixed point, and his tongue did not have much tone at all. It has a little bit of fasciculations in it if you look really closely. So he struggled to eat as well. You can see him here chewing, but he's never quite swallowing if you really look at it closely. So sometimes horses can chew, but not swallow, which is such a coordinated effort. So horses can have such a constellation of signs. This is, I don't quite remember. Oh, this horse is really cool because he exhibits a good example of the sort of goose stepping or slapping of the hind limb. So take a look at the way he walks. He has a really spastic step, unlike the other guys who were kind of slow and dragging. So EPM can look like this as well. You'll see him walk away and still just kind of goose stepping, slapping his legs. If you had audio in this video, you would just hear him slapping the pavement with his feet here. See what he does next, because I don't quite remember how this video ends. Be a surprise. So here he is circling. So we'll see him circle. He crosses over better than the other horse, but still doesn't do it very well. He's a bit quicker on his feet, but still doesn't exhibit crossing over very well. And then as he reverses, he struggles to reverse. So most horses will reverse in diagonal pairs pretty readily, but he gets kind of overwhelmed and disorganized. So his signs are a little bit more subtle than the other videos. And then this horse is a really nice example also of abnormal circling. And he has a very long stride in all four limbs. So I'll let you watch him go. See how long those hind limbs are striding out in the circle? He has what we call circumduction, which is a fancy word for excessive outward swing of the outside hind limbs. Hopefully you can get a sense of just how he really widely swings those hind limbs around. And again, is not crossing over appropriately. And sometimes he'll drag footing as well.
These videos kind of remind me sometimes of like what a horse would look like after they've had sedation for a dental or something.
Yes,
and you're walking them back to the stall where they're kind of drunk, you know?
Totally. Yes. So sometimes these horses look like they're sedated when they're not. And he really struggles to reverse, as you'll see demonstrated again here. He was a really lovely horse, but he just kind of struggles. You can actually see him grimace a little bit here too. Like it's just really hard for him to reverse. So, and now we've talked about what we do when we see these horses, and we formulate our list of possible, what we call differentials. So usually our big three, we call them EPM, EDM, which is neurodegenerative disease or equine degenerative myeloencephalopathy, and CVSM or wobblers, which is cervical vertebral stenotic myelopathy. The reason why I bring up these big three is because they can all look identical. So EPM and CVSM and EDM, this alphabet soup, they can all look exactly the same. So how do we tell them apart? Well, there are a couple of things we can do. One is a CSF tap. So the best way to rule in or out active EPM infection is to compare antibody production in the cerebrospinal fluid and compare it to blood. So there are blood tests, there are CSF tests, and then there are tests that combine and compare them. And the gold standard, I'll say, in the living horse for diagnosis is comparing blood and CSF against each other. And what we're looking for, the reason why comparison is important, is because so many horses have antibodies in their blood because they've seen the pathogen. Remember, like it's everywhere. It's in the streams and in the grass. And so many horses are going to see the pathogen, consume the pathogen, and just pass it right along and live their lives normally. But every now and then, one horse in a bunch of horses is going to get true neurologic infection. And so in the cerebrospinal fluid, we count, I mean, not me personally, but the people that work in the laboratories will have machines that can count the number and amount of antibody that's produced in the cerebrospinal fluid and compare it to what is in the bloodstream. And there are ratios that are created that basically tell you that, yes, there's a really high number of antibodies that the horse is making against the pathogen in his CSF compared to his blood. If we look at blood alone, we have no idea if the horse is actually dealing with an infection. A positive blood test tells us that the horse was exposed to the pathogen, but it does not tell us if his central nervous system is currently riddled with infection. So doing that comparison is really important. So the conclusion of that is that doing blood tests alone has really low, what we call specificity. This means that there's a high rate of false positives. So almost every horse in my tri-state region, I think realistically maybe close to like 75 or 80% will have positive blood tests, but it doesn't mean that they're infected. The best way to tell if you have EPM, unfortunately, is post-mortem, but none of us want to end up there. And so ideally we'll use the CSF analysis with the blood. But there are a variety of reasons why people might not want to do that. And that's okay too, because a CSF test requires somebody that knows how to do it. It requires a safe place to do it. It requires a good handler, some sedation, like the situation has to be appropriate for CSF analysis. And it's not going to be right for every horse and it's not going to be right for every owner. But the best way for us to identify it is to compare CSF and blood. So with that, I'll pause because I know that we probably have some questions about this part of the talk.
Yeah. Do you think there will be a vaccine at some point in the future? Is that on the horizon?
There was some research about vaccines, but it was so hard to do because of the things I described in terms of like having a standard set of horses to test it. Because if we don't know how to induce it, it's so hard to know what the efficacy of a vaccine is, right? Because like, how do we know it's working when it's so random almost which horses will actually get EPM? So the production, I believe, is currently at a standstill, or rather, I should say the research and development aspect, as far as I know. So unfortunately, right now, we do not have a vaccine. It's possible that there's some research going on that I'm just not privy to, honestly, very possible, but I'm not aware of anything right now in terms of moving forward with a vaccine, unfortunately.
And when you talk about cerebral spinal fluid, what is that like a layman's term for that would be spinal tap? Is that?
Yes. Yeah. I'm glad you asked. I should have mentioned that. So this is what we would call spinal tap. There's a picture of me doing one right here, which you can't really see super well, but doing a spinal tap in a horse is something that we can do in the hospital relatively easily, but in the field is a lot harder. Honestly, I am not the bravest person, and I would probably be really nervous to do it in the field without having my stocks and my handler and all my drugs and, all the like things that make it easy for me to do in the hospital. So it can be really hard to do in the field, but there are definitely some general practitioners that do it in the field too. But yes, a spinal tap is what we mean by that in terms of collecting that fluid. And the CSF is the fluid that bathes the brain and the spinal cord, and they all communicate with each other. So it's sort of a continual space full of fluid. And there's a lot of information we can get from the fluid. So we can look for those titers for EPM. We can look for titers for Lyme. And we can also just look at the cells that are in the CSF that are around the brain and cord. And sometimes we can find weird stuff, like weird bacterial infections or even cancer in very rare cases.
Oh,
so the spinal tap can be a wealth of information.
oh. Karen asked, is it possible that you could see a transient period of ataxia? So like horse is ataxic today and maybe later that evening they're not. Like, does that happen with symptoms where they come and go? Are they pretty fluid like that?
Great question. They can be, and they can change like morning to night or even sometimes day to day. Some horses might be more demonstrative on one day versus the next. Usually it's not like a huge difference though, I would say. It would be weird to have a horse have really severe signs in the morning and then be fine at night. That would be a very strange scenario, but not impossible. So I would say usually they're relatively consistent, but there can be some day to day or like regionally within the day changes depending on how tired the horse is, if he's trailered somewhere. Exhaustion and weakness can contribute to what signs look like. So that could possibly be a factor.
And Rebecca asks, is the spinal tap expensive? Is that an expensive diagnostic? I know we're going to talk about costs at the end, but
Yeah, we are going to talk about costs at the end. So my short version for now is that it is not very cheap. So usually for new Bolton Center costs, and this can vary where you are in the country and what hospital you are and how much everything costs. So it's hard to compare hospitals, but just to give you a sense of what we typically charge in terms of the cost of the whole kit and caboodle. So like the sedation, the needle, the equipment, the active tapping, and then the diagnostic tests for EPM. And usually we do Lyme and look at the cell types is around $800. The cost of treatment, so when we do 1 month of Marquee, for example, is for our hospital around $1,030. So it's a little cheaper than treating for EPM for a month. And some might argue, well, yeah, maybe I may as well just treat then instead of test. But later I'll talk about how there are many horses that don't actually have EPM. So you treat them for a month, but then you're back at square one because they haven't improved. And then we are tapping them to make sure it's not EPM. And so then that cost comes up anyway. And so we'll talk a little bit about that towards the end. But honestly, it's not wrong for either owners or practitioners to decide to treat empirically, meaning just treat them and see if it works. Like that is not a wrong approach. In this ivory tower where I work, and we try to, be good academicians and have as much evidence as possible. When we have the money to do it, it's great for us to know, but that doesn't mean it's right for every person, every horse, and every vet. And so it's perfectly reasonable for an owner and or a vet to decide that in their situation, they would like to just try treatment and see if it works. And we'll talk about the different drugs and the fact that they're quite safe generally. And so empirical treatment, meaning treating without knowing what you're treating, is not wrong either. So it's not a one size fits all thing. In the academic setting where I live and work, we like to, know as much as we can, but that doesn't mean it's the only way.
Perfect. Thanks. That's all we have at this moment for questions.
Awesome. These are really good questions. Oh, and then here's the last bullet, which is to that point, some rely on response to treatment. So treating a horse and seeing if it gets better, that's decent evidence as well. So if that works for you, then you are fortunate. You have hit the lotto, have not had to do a spinal tap, and have had a horse respond to treatment. And God knows that happens all the time. So it's sort of a cost benefit analysis, which is why I am going to talk about that in just a couple slides. So one of the things I wanted to bring up is the actual sort of evidence for how common it is for positive blood tests. So this was a piece of literature by James Prosterla and colleagues that was published in 2017, so not terribly long ago. And what you're looking at is called seroprevalence, and that means positive blood tests for EPM. So in each region of the country, they've conveniently split this infographic into Sarcocystis neurona titers and Neospora husi titers. And so you can see that so many horses in these areas were seropositive, meaning had positive blood tests to either Sarcocystis, Neospora, or even both. 31% of the horses in this whole study were positive for both. And then some horses were negative for both. So the one thing I didn't mention in the other slide is when a blood test is positive, it means that the horse has been exposed, and we don't know if he's actively infected or not. But if a horse is negative on some blood tests, we actually have pretty solid confidence that he doesn't have EPM. And that varies in different parts of the country. So where we are in Pennsylvania and thereabouts, so many horses have positive blood tests, right? So if a horse is negative, in our area, that's pretty good evidence that he doesn't have EPM, because what are the chances that he has not seen the pathogen. They're so low. So we actually can hang our hats on a negative blood test with relative confidence. So if you're debating doing a spinal tap and you do a blood test and it's positive, well, you don't know if your horse is positive or not, truly. But if it's negative, you can actually feel pretty good that that's not what you're dealing with, and maybe you forego the spinal tap. At the end of the day, the spinal tap is going to be our best way at this point in the living horse of saying yes or no with absolute certainty. But a negative blood test can be helpful because it does suggest, in our area anyway, that they're not necessarily exposed. Now, out in the West, so like in California and thereabouts, it's a little bit less certain, because if you look on this map, only 68% versus the 82 in our area are seropositive. And so your potential for a false negative is a little bit higher, if that makes sense. So at the end of the day, conferring with your veterinarian about their recommendations for testing and, asking their experience in your area, et cetera, is going to be really helpful.
I do have a couple questions. Do you want to knock them out now, or?
Yeah, we can knock them out now.
Okay. Donna wants to know, doesn't a blood test have the scale of antibody level that indicates a full infection versus exposure? So is that scale of antibodies reliable?
So the short answer is no. So for the SAG-243 ELISA, which is the one that we use a lot, there's also the IFAT out of UC Davis. Those are the two big ones. For the SAG ELISA, they give you a ratio of like 1 to 1,000, 1 to 4,000, et cetera. And the magnitude of the titer does not successfully predict active infection. So even if the titer is really, really high, it doesn't make us more convinced that this horse is actively infected. There are some pieces of information associated with the IFAT test out of Davis where they do correlate the magnitude of titer with the likelihood of infection. And so those might help you a little bit, but the long and short of it is that generally we consider a positive blood test to tell us that a horse has been exposed, and otherwise we don't have a way of getting more confidence that it's an active infection versus not, which is frustrating. And I think a little bit maybe misleading sometimes, but at this point, the titers really are not useful for us to know that the horse is absolutely infected just based on blood alone. So having the combined blood with cerebrospinal fluid is our sort of best way to know.
And Steph, I'll just read her question. She has had 2 cases of EPM on her farm in 3 years. Both were nursing mares. One Frisian recovered. The recent one a few weeks ago was half Arabian, and she declined very quickly. She would like to know if there's anything that she can do to protect her other breeding mares on her farm.
Oh, that's a good question. We do have a slide probably coming up in the next couple where I talk about what we can do, how we can do our best to prevent this disease. And there are a lot of aspects of it that are out of our control. And I'm very sorry that you had to deal with that twice. I can imagine that that was really gut-wrenching, and you're probably wondering if there's anything that you can do to help prevent this in the future. So we'll talk a little bit about what we know. Unfortunately, there are so many aspects that we can't control, which in a way sort of relieves us of some of the pressure, but at the same time, doesn't give us a lot of opportunities for prevention. So I'll talk a little bit about the different management strategies that we can use to try to prevent this disease. And then some of the newer pieces of literature are suggesting that sometimes maybe you can try prophylactic treatment on farms where it's endemic, but those are very early on in their research stages. And so it's not yet recommended to just like blindly treat as like a prevention strategy, but there is research going into that. So I mentioned that just to kind of spread some seeds of hope that eventually we'll have some sort of protocol that we can really try to implement to prevent this disease. But right now it comes down to a lot of different management strategies. So I'll talk about those in a couple minutes.
All right, perfect. We're all caught up right now.
All right, great. So treatment, there are anti-protozoal medications. There are 3 that are FDA approved on the market. So Rebalance, Marquis, and Protozil, and they are all 3 different formulations. So Marquis is a paste, Rebalance is a a liquid, and then Protozoal is a pellet. And so we always say the best anti-protozoal is the one that your horse will consume. So pick the one that either your veterinarian has to dispense you, and or the one that your horse and management strategy can use the best. So for some people that's a pellet, for other people that's a liquid, and for other people it's paste. Usually in the hospital, we'll use the paste just because a couple of reasons. One, we know that all of it is getting in the mouth, like we're administering it. So instead of using a top dress, it's something that we are, witnessing the horse consume in its entirety. So we can feel a little bit better that they're getting all of it. The other reason we will reach for Marquis is that instead of having our clients buy an entire bottle or an entire bucket of pellet, if we're waiting on test results, for example, and we just want to start them until we have our results back, and if they're negative, we can discontinue and save our clients money. Starting with one paste that lasts a week at a time, roughly, then we're not investing in the entire month of treatment. So it kind of just depends on the cost, the way your horse consumes the medication, and sort of how you're treating. But conferring with your veterinarian is definitely recommended. There are a couple other different treatments that you might hear about out there, but these are the only 3 that are FDA approved, and usually the only 3 that we use. Some vets have had experience with other different medications or compounded medications. So again, conferring with your vet in your area about their experience is going to be helpful. Usually we will combine anti-protozoal medication with anti-inflammatories. And the reason is that in addition to the damage caused by the parasite itself, once we treat these guys, sometimes when the parasites die, it stimulates an immune response. And you want that to a point. You want the horse's body to fight the infection, but sometimes the body is a bit over exuberant, and the body's own efforts at ameliorating infection can cause more damage. Think of it almost as sort of like an offshoot of an autoimmune type of situation where the body is just attacking so much that it's actually damaging its own self. And so simply the act of inflammation can cause more issues. So we'll often combine with anti-inflammatories. Usually we'll start with Banamine, but sometimes we will do a steroid like dexamethasone if the situation is extremely dire. Other times we'll hold off. But again, your veterinarian will kind of choose what they feel is best in their experience. And then the last little bit, I don't think that this necessarily makes or breaks a case, but we will often put these guys on vitamin E. So Elevate is an example, Nano E, M-Cell, there are a bunch of products out there. And the reason why vitamin E is thought to be important in any neurologic situation is that it is an antioxidant, and oxidative damage can happen in any neurologic disease. So if there is a neurologic insult and we can try to heat it off a little bit with a antioxidant, it makes us feel a little bit better. We can sleep a little bit better at night knowing that we're doing everything we can. And so in some cases, we will try to do some neuroprotectant with vitamin E as well. There are very minimal side effects associated with antiprotozoals, but they're not completely benign. So, I mentioned that it's not wrong at all to empirically treat. And in the rare cases where there are side effects, you can see what we would call a transient anemia. So some horses will get mildly anemic, but usually it self-resolves without intervention. Some horses will have a self-limiting diarrhea, but anytime horses have diarrhea, it can be an emergency. So it's important to consult with your veterinarian if you see any of these side effects. And some horses will become anorexic or go off their feed. The other thing to think about is the anti-inflammatories can also have side effects too. So if you're seeing any issues with your horse at all that happen after starting medications, definitely let your veterinarian know, but they are considered relatively safe. Are there any questions?
I have a couple questions here. Is there a significant difference in the cost between those 3 treatments, or are they all pretty equal?
That's a great question. There are some cost differences. I can tell you with certainty that a month of Panazaril or Marquis is $1,030 at our institution. The other 2 I don't use as frequently, so I can't tell you exactly what they cost. The thing about them, I think that's more important than the actual cost is like how much you're getting. So that's why we use Marquee a lot, because we can buy like 1 week at a time. But if you know that you're going to be doing, 1 to 2 months, then maybe buying the bucket of the pellet is going to be more cost effective. So it really comes down to what the costs are at your institution or with your veterinarian, and also how long you're going to be giving it and what the horse likes to eat. So some horses don't like Protozoal pellet. You're going to be disappointed if you purchase that whole bucket and they don't consume it. So it just really depends on your individual situation, but there are cost differences between the three.
Okay. And Andrea asks, is there a preference for treatment? And are there options for a horse that still shows signs or damage years later?
Oh, those are tough questions. So in terms of a preference for treatment, no. The three medications, I'll put up this slide again. The three medications that are FDA approved have relatively similar levels of efficacy. So in the literature, they're all somewhere between 60 and 70% effective. So we don't necessarily consider one better than the other. It's the best one is the one your horse consumes. So with that though, that means only 60 to 70% are going to improve potentially. So that reminds us, and we were talking a little bit again before this webinar started, we saw a horse a couple of weeks ago that despite all efforts, and we pulled out all the stops, the horse just did not get better. And there are occasionally horses with EPM that don't respond to treatment, and it's just bad luck. And so there's not one treatment that's better than the rest. If we've tried one treatment and the horse hasn't improved in a month, sometimes we'll do combinatorial therapy, meaning we'll include another medication just in case the horse responds to that one instead. But in general, we don't consider one better than the other. The second question about what to do if problems persist years later, it's really hard. So some horses will have a plateau. They'll get better a little bit or not, and then they'll stay where they're at. And that is just where their neuroregeneration qualities end for whatever reason. So some horses just plateau where they are. And unfortunately, it doesn't seem like if the signs have been there for years that there's going to be sort of like a miracle treatment that fixes them at that point. Some horses just stay where they are in their recovery, unfortunately. So there is not really like a strategy essentially at that point, unfortunately.
Okay. And Nicole asks, if EPM has gone undetected and untreated for too long, is the likelihood of a recovery compromised?
It can be. So it's considered that the quicker that you start treating these guys, the better outcome they have. So that's why some people will just start empirical treatment right away. If we have a high suspicion of EPM, it takes a couple days to get our spinal tap back. We'll start them on treatment immediately if we really think that's what we're dealing with. So it does seem to be that horses that receive treatment earlier might have better outcomes. So the better or the earlier that you start treating them, the better that the chance they have at recovery. But the other thing is severity of symptoms is associated with prognosis too. So the horse that's down and out and can't even get up and needs a sling is going to have a much poorer prognosis than one that has a droopy eyelid and, is walking a little bit funny. So the gamut of symptoms can dictate their prognosis as well as maybe how soon you start treatment.
Okay, that's it for now.
All right, awesome questions. So this is where we get to prognosis. And then I only have a couple more slides because some of them is the financial analyses. So I'll be able to kind of speed through those and just give you the highlights since we are somehow already at 8:00.
That's okay. Just keep going. That's all right.
Perfect. Prognosis. So for horses that are more severely affected, about 60%, as I mentioned, will improve at least one grade. So do you guys remember that scale we talked about, the 0 to 5? So the grade, obviously it's subjective, but most horses will recover at least one full grade. So if a horse is only a grade 1 or 2, he has a pretty good chance at being normal again. But if he's a grade 5, your chances are not so good. But horses can surprise us all. They surprise me all the time. 10 to 20% will completely recover. Those are the lucky horses, but some horses relapse, and there's not a ton of research into how or why these relapses occur, but we know they can happen, and they are terribly frustrating. More mildly affected horses seem to have a considerably better outlook. Seems like up to 80% of those guys will improve and at least 50% of them completely recover. So recovery rates for more mildly affected horses are definitely more encouraging. And in terms of prevention, there have been a lot of questions about this. So I'll tell you what we can do. And it's going to seem probably, I don't know, almost fruitless in some situations. But what we do know is that trying to essentially decrease the surrounding wildlife and possum influences on our day-to-day horse management. So things like closing feed room doors and feed containers and keeping them sealed. I wish I had this picture. I had a photo sent to me by a friend who opened the trash can lid. This is like the most ridiculous thing. Opened the trash can lid in her feed room, and I swear to God, a possum is sitting in the feed bin, like eating the grain. It's like the most ridiculous thing. So she absolutely threw that away. But I bring this up because it highlights the importance of just trying to minimize the attraction of wildlife into our barns and into our feed rooms. And along those lines, using like raised feeders versus just kind of throwing feed on the ground. So doing that where it's feasible and possible, and not all management situations lend themselves to this. And we can only do what we can do and do our best. Cleaning up dropped grain. So like, especially in those horses that are quitters, like the ones that are a bit older, maybe have poor dentition or teeth, and they are just known for dropping a lot of grain. So sweeping up after them. Again, there's only so much we can do about that. And then implementing rodent control when you can. So trying to keep the rodents under control. And so even though mice and rats don't necessarily have like a direct relationship in the life cycle involved in Sarcoidosis neurona, they might feed some of those creatures that do. And so trying to just implement general rodent control is recommended. And then I can't actually read my final bullet. Okay, here we go. Ensure proper equine health and fitness. So going back to the idea that keeping our horses as healthy as possible and keeping their immune systems as up to snuff as we can seems to have favorable outcomes. So before I go into the research, I know it's late, but are there any questions?
Yeah, don't worry about the time. We're okay. Cat food. That's a big thing in the barn, right? So we want to keep that covered up. And then
definitely.
what about fencing? Because if you had like no climb fence, that's going to be a lot harder for a possum to get through versus something like poly rope or.
Yes. Yeah, for sure. So if those are things that are amenable to you, like that type of fencing, and like, it's not like we can all go out and just change our fencing. But of course, those sorts of things might be helpful. There's no explicit literature that's like, this fence is better than this fence. And I am not aware enough of the athletic abilities of the possum. So I can't say with huge confidence, but it does seem like whatever efforts can be made to sort of minimize possum influence are important. And really quickly, this is sort of funny, but I think just very sweet. I once had an owner come up to me after a talk like this, and she was talking to me about how she wanted to buy this horse, and she was getting all set to like do the pre-purchase. And then she noticed in the background of the sale photo was a possum like on the grass. And she was like, do you think I should?
No.
Yeah, she's like, do you think I shouldn't buy this horse? And I was like, oh my goodness, like, what are the chances? So just minimizing possum exposure. I did not tell her not to buy the horse. We have no idea if that possum was a perpetrator, but needless to say, the importance of trying to keep them out, and wherever they live, EPM shall persist. So there's only so much we can do. It's a really fascinating disease, but it's frustrating because we're so limited in what we're able to do. And the EPM updates, should I go on to those, or do we have another question?
We have like 4 questions.
maybe I'll do the updates real quick, and then we can just
sure.
They're unfortunately not huge. So a couple of the areas that research has been focusing on are like preventative strategies. Let's see if I can move this. Okay. So updates include dosing options. So this was a study published in 2021 looking at the use of biweekly administration of diclazeril, which is Protozoal, on antibody kinetics of Sarcoidosis neurona. So what that actually means in English is that they wanted to see if giving horses twice a week Protozoal, so this is actually half the labeled dose, so it's not the full cost and dose of like a normal administration. As a top dress for a year, decreased the number of horses that had positive antibody titers. So like, did it stop them from consuming this parasite and having the parasite lead to the development of antibodies in their blood? And initially, they did see decreased numbers of horses with positive blood titers. So it seemed like it decreased the number of horses that saw enough pathogen that they created an immune response about it. But eventually all of them had positive blood titers. So it wasn't super encouraging. It did offer some promise initially, but there's only so much that we can extrapolate from what the blood titers mean, as I've said a few times. So could this still maybe in the future offer some sort of like preventative option for horses, especially on farms where we know that EPM exists? Maybe. Some farms and individuals and veterinarians are recommending different strategies like this to try to prevent infection. But as of now, we don't have any literature, and I can't sit here and lie to you and tell you that giving this medication twice a week is going to stop your horses from developing EPM. So we just don't know. The other thing is it has not been evaluated in treating active EPM infection at this dose. So we also can't sit here and say that using half the dose and saving half your money is still going to be effective treatment. So there are definitely limitations there. This one's kind of fun, I think. My idea of fun might be a little bit different, but this study looked at the administration of corn oil, which is something that I think, I mean, when I was a kid, we used to use corn oil all the time as like something to help with healthy coats and just like good fats and stuff like that. And this study identified that using corn oil with Panazeryl, so that's Marquis, one of those treatments, that's the paste option, increases the concentration of drug in the cerebrospinal fluid, that stuff that we get on the spinal tap, and in the blood levels as well in horses. So they gave these horses Marquis and then also gave them Marquis with corn oil. And they did 2 ounces of corn oil with the Marquis, which is given once a day for 21 days. And the goal of the study is to see if they could increase the levels of the drug around the central nervous system, because maybe that's a way that we can improve treatment. So like some of these horses get better and some of them don't, right? And maybe they just need higher levels of the drug to fight the infection. So what they saw was that they did in fact get higher levels of blood and CSF concentrations of Panazeryl with corn oil. And so some horses, when we treat them, maybe they get higher levels of the drug. So are we able to like boost the amount that what we're putting in their mouth actually gets to their central nervous system? So in the hospital, we will often now include corn oil when we're giving Marquis, because maybe it helps some horses. It certainly doesn't seem to hurt anything. So this was actually something that we use clinically. So that was kind of cool. I know it's a little bit minimal, but any step in the right direction, I think, is worthwhile. And then this is the last one. So this was a study that wasn't exactly just EPM related, but basically there are 3 ways that we do spinal taps. So one is in this picture here is one of my residents. She's so happy because it's so much fun. So she is doing a lumbosacral spinal tap. So this is the one that is back by the rump. So we place a needle. It's a 6-inch needle, so it's pretty long, and we go into this tiny little space between the lumbar and sacral aspects of the vertebral column or the spine, and then we obtain fluid. So you can see a little bit of fluid in our syringe there. So this is the lumbosacral tap. It is the safest one for the horse, we think. It's farthest from the brain, so if anything bad happens, we're all the way back there. It's unlikely that we're going to have any issues, but it's the most dangerous tap for us because we're standing by their hind end. And let me tell you, some horses, they can actually have really big reactions when we hit what's called the dura mater, which is one of the layers that you hit before you get cerebrospinal fluid. And in people that get spinal taps, they've reported that sometimes the needle, when it hits this part, it sends this almost sort of like electrifying sensation, not necessarily painful, but sort of surprising. And we can only extrapolate that horses feel this sometimes too. So probably like 1 in 80 spinal taps that we do here at this location at the lumbosacral space, as soon as we hit the dura, we think The horse loses their mind, tries to exit the stocks. We had one the other day that kicked the mounting block that our operator was standing on. So it can be really dangerous for us. So there are two other options to do spinal fluid analysis. One is the atlanto-occipital space. So it's the base of the skull and the first vertebrae. And we can only do that really safely under general anesthesia. So that's what we use for like myelograms and stuff. But we can't do that in a standing horse. So most owners don't want that option. And then the last option is called C1, C2. It's between the first and second cervical vertebrae and uses an ultrasound probe. It's actually pretty slick, but not everyone is comfortable doing that procedure. And there are some complications that we don't have time to talk about. So anyway, the point of the study was to see if there are any differences in the analyses that we get from these sites. Because what if when we're tapping back by the rump, we're missing EPMs that we might be able to diagnose if we tapped them more forward, like by their brain, for example. And the result of this study is good, which is that it doesn't seem like there's many differences between the sites. So it doesn't make us want to do one site over the other one. So that was sort of the conclusion of this study. And then finally, and then we can just do questions endlessly. The last thing is the financial analysis that I alluded to at the risk of being self-indulgent. And we wanted to assess the cost of diagnosing and treating using different approaches. And we also wanted to see which tests in our case population were the most accurate, meaning just using blood, just using spinal fluid, using them both, or just using clinical signs. So I'm going to just try to break this down really simply because I could just go on and on about it. But we basically used a reference cost, which is where we totaled the number of dollars that you would spend to treat every single neurologic horse that walked in our door. Meaning, if we just assumed they all had EPM, they would cost X. And we did that for 1 month and 2 months. And that was sort of our reference. Then we broke it down and instead said, what if we only treated the horses that were positive for these different diagnostic tests and wanted to compare them and see how much money we saved if we only treated the horses that were positive based on the different criteria? So the second step, and then we'll get to the conclusion, the second step was to see which tests were the most accurate. So this slide, if you pay attention to the very bottom of the slide, this signs plus titer ratio basically means comparing blood and CSF and using that ratio. And it was by far the most accurate compared to just using neurologic signs, which was only 12% of cases, just using a positive blood test, which was 34% of cases, just using CSF, and then looking at different ratios. So the most sensitive test in our population, most accurate test, was the comparison of CSF and serum. And then the last conclusion for this study is that 83% of our neurologic horses that walk in our door at New Bolton Center in this study were positive on their blood tests. That is so many horses. But only 12% of the horses that walked in our door actually had EPM. So what that means is if you just treat every neurologic horse that walks in the door, or rather treat every neurologic horse that has a positive blood test, you are oftentimes going to spend $1,030 to $2,060 more on your treatment because you treated before testing rather than just starting with the test. So this cost of $547 is the cost of just the tap with the EPM analysis, not the Lyme and everything else. So the conclusion is that the CSF with the blood is the most accurate, but also that the by and large, if you're just testing based on a blood test, you might end up spending over $1,000 to $2,000 more than you would have if you started with a CSF tap.
If I was in church right now, I'd say, amen.
I love that. There are many limitations to this study. We have a low prevalence of true EPM in our area. So even though the horses are positive a lot, the prevalence is low. So if you did this study in California, it might be different. In the Midwest, it might be different. So please take these with a grain of salt. We also have a referral population. So our population isn't necessarily all of the horses that the general practitioner sees. Our horses come to us because people have been struggling for a long time. They've already done a lot of diagnostics and they're not getting anywhere. So we might be weeding out a lot of true EPMs before they walk in our door, right? So like, we don't know that all horses are represented by this population. And for the future, we're hoping to do this analysis with other institutions to get a broader sense of what we're dealing with. So with that, I would love to thank Angie, the Fenway Foundation, obviously New Bolton Center, of course, and Dr. Johnson. And if anyone here has more questions than what I'm able to answer tonight, I mean, you can email me for sure. But on this website here, the ACVIM, it's the internal medicine governing body, there's something called a consensus statement, and it is a little bit science heavy, but I do think it offers so much information and kind of is a beautiful summary of what we know and what we don't about the disease. So if you're ever curious, that's a really nice resource. But with that, I'll take further questions that you have.
I think you're this is like the most questions I ever remember having in a webinar. So it's great. And they're all such great questions. So we have a few from Facebook and we've got several here. So as we're going through the questions, guys, if you're in the audience and you're thinking about asking a question or there's something on your mind, now's the time to type it. Because when I get through these questions, we're going to wrap things up and end the webinar. So this question is from Linda, and she wants to know if she was looking at a mare to purchase and there was in the vet records incidents of EPM that have been treated, is that a horse that you might screen a little more carefully if you were to buy it? Or are there, any diagnostics that she could do that would be helpful for her before she purchased that horse?
So it's definitely hard to know, because when you treat a horse empirically, so you're treating a horse without knowing if it's truly EPM, we don't know if that mare had EPM before. But the thing that gives me pause is that usually you're not treating for no reason. So if they went through the trouble of treating this mare, regardless of testing or not testing or doing spinal fluid or not, it makes me pause that they had a reason to do it. Like, did she have neurologic signs, whatever is causing them? That would give me pause. So I would maybe try to ask more questions about what led them to treating this mare for EPM. Did she improve with treatment? So probably just get a little bit more of an information gather, but it would be hard to know what it truly means for the horse in front of you. So in addition to getting information about why they tested or treated or both, I would also, of course, have your vet do in their pre-purchase evaluation, include a neurologic evaluation as part of your pre-purchase. Make sure that there are no lasting or evident neurologic deficits that might be limiting to your uses of the mare.
She says where she's going with that is she's worried about purchasing the horse and then the horse having a relapse. She says it's a recent, within the last year.
Okay. Yeah, I think it would go back to finding out why they treated her. Did she improve? If she improved, maybe that increases your suspicion that it was EPM. Relapses are possible, but they don't always happen. So it comes down to cost benefit analysis. And I think having the neurologic information of today's evaluation on that mare is going to be helpful for prognostication. And ultimately, you never know who's going to relapse or not. So it's sort of a risk that you have to kind of go in knowing that you're taking, unfortunately.
Marty asks, do we need to be concerned about our hay? If I'm purchasing the hay from the same farmer and I've gotten more than one incidence of EPM over the years, is there a risk that there are infected possum feces in my hay?
Good question. Hay is one of just many possible reasons why a horse may come into contact with possum excrement. So is it possible that the hay was related to that one incidence of EPM? It's possible, but it also could have just been the fields on your farm. It could have been the water sources. So there's just no way of knowing if it is the hay. I think that if I was a betting woman, I probably wouldn't bet on it, but you never know. There are just so many variables though. And so I don't know that one incidence of EPM would be enough to make me switch suppliers. But at the end of the day, it's anyone's guess, unfortunately.
Christy asks, is the relapse the same for mildly affected horses? So in other words, you had that one slide talking about the outcome. So do you see the same amount of relapses in severe horses versus mildly affected?
That is a great question. Me personally, I've seen so few true relapses. My my kind of gut and anecdotal response is that the more severe the signs, the more likely they are to relapse. But I don't know that that's been absolutely documented in the literature. But generally, horses with worse disease will have worse prognosis. And I feel in the couple of relapses I've seen are more likely to relapse, but still a kind of a question mark there.
Christy asks, can cattle also get EPM, or is it just horses?
So EPM specifically refers to equine protozoal myeloencephalitis. There is not a super well characterized protozoal disease in cattle that I'm aware of, but there are some coccidia that cattle can get. There are coccidia that dogs can get and carry. And there have been some research studies trying to see if some of those coccidia associated with other species on the farm can cause EPM in the horse, none of which have been truly demonstrated. But my short answer is that there is not a kind of obvious cattle equivalent, I guess. There is a disease in ruminants that's known as P. tenuis or Paralephostrongylis tenuis, which is sort of like a similar disease to EPM in that it's this organism that can kind of worm its way around the CNS. But I wouldn't say there's like that cattle can also get this same disease. It would be a different process.
Okay. And Becca asks, what do we know, like what percent of possums carry these protozoa?
Don't know.
Don't know. Okay. Christy asks, if you had a horse that had a mild EPM case and did 2 rounds of treatment with great success, would you treat them before a stressful situation as a preventative for another relapse?
That is a good question. So there are cases where we have had a horse recover from EPM well. And in theory, one could argue that if a horse succumbed to EPM, perhaps he is more likely to succumb again. And maybe that's because he, for whatever reason, whether it's his immune system or what have you, was not up to snuff. And so in some cases with very motivated owners, we will sometimes put them on a prophylactic lower dose antiprotozoal. So that would be something to talk about with your veterinarian. But sometimes we do that because you can argue that the horse that's had it before is more likely to get it again for whatever that reason is or those reasons. So yes, we have put horses on continuous sort of preventative type treatments after they've made full recoveries. It's not cheap, but it can
I bet not.
It can be done.
Nicole asks, what do you recommend if your horse is unable to travel for a spinal tap?
Oh, that's a good question. So that's a very valid reason not to pursue one in certain situations. So there are some vets that feel comfortable doing it in the field, especially as I mentioned, that C1, C2 option, which is between the first and second vertebrae. It's actually a bit safer in some situations to do on a farm than doing that standard lumbosacral one, the one back by the rump, because you're up by their head. It's easier to do with less assistance and without stocks and all that stuff. So some vets are becoming more comfortable doing taps in the field. But if you can't do a tap in the field, that is a limitation. And if you can't trailer it into the hospital either, you can't do it. So at that point, you have to decide with your veterinarian if you want to try treating empirically or look for another source of your horse's clinical signs. So if you can't tap, you can't tap, and that's okay. And there are many reasons why people choose to treat over tapping. It just can be limited.
Debbie asks, does ivermectin help maintain the horse with a horse with EPM?
Ivermectin is not a treatment that we employ for EPM. There's no studies to suggest that it helps horses with EPM. We do use ivermectin in the ruminants that we treat for that other disease I mentioned, P. tenuis, which is unrelated to this. But no, there are no studies suggesting ivermectin's efficacy against EPM. It's a good question though, because it is also like it's an antiparasitic, right? It's not an anticoccidial. And so these organisms are distinct from the worms and things you would treat with ivermectin.
Heather asks, do you ever use thermal imaging as part of a diagnosis or to support your diagnosis?
That is a very cool question. As of now, no. I know thermal imaging is sort of gaining some speed in some circles for different diagnostic uses. I know I've seen it used in attempts to localize like sources of lameness and musculoskeletal problems. In my experience, excuse me, we have not employed thermal imaging, but that's a great question. And I'd be excited to see if it does become something that is useful for us in the neurologic field.
That's fascinating. This next question I think is really interesting too. It's from Kate, and she asks, how long do the protozoa live? And she's kind of referring to the hay question. So she says, for example, does the protozoa in the possum feces, like, for example, like if it was in your compost pile, is it going to degrade and not be effective, or does it need to be very fresh feces that they ingest? Do we know?
We don't know. I feel like a broken record, but I would just be lying to you if I was making things up. But we just don't know. There's so much we don't know about many facets of neurology, which keeps me really humble a lot of the time. But unfortunately, we just don't know.
All right. Well, that was the last question, believe it or not. I think this is a record for webinar questions, which I
That's
just love.
awesome.
This was excellent. I think it's something that so many people have either experienced themselves or know someone that did. I think you gave us a lot of good information about diagnostics, and I think you cleared up a lot of fuzzy areas about treatments and costs, and I thought it was fantastic. So in conclusion, thanks to everyone for attending tonight's webinar. Like Dr. Colmer said, if you have additional questions, you can submit them to us at Fenway Foundation, and we will make sure that they get over to her. You can email us at info@fenwayfoundation.com. This webinar was recorded. It's also on Facebook Live. So if you want to view this webinar later, you can explore this webinar and hundreds of other educational articles that are in our library by going to the Fenway Foundation website, which is www.fenwayfoundation.com. So if you register for this webinar, you will get an email and a link to the recorded webinar if you want to go back and refer to it. So thank you so much, Dr. Colmer. This was it. I hate to say that this is a fun topic because it's not, but I think it was just fascinating. And you're such a great presenter. You're so much fun to listen to. You're such a great teacher. So
Thank you.
I hope that we'll have you back again for another neurological related webinar. So we'll have to talk about that. But thanks so much.
Absolutely. My pleasure. And thank you all for your amazing questions. Honestly, that was really, really stimulating for me too. So keep asking questions and I will try to answer them.
Awesome. Thank you so much. And we'll see you guys on our next webinar. Good night.